I talked about the long-term complications previously with the mnemonic knives, but it's really important that you know what teaching points or what you have to remind patients to do to maintain tight glycemic control so that they don't develop these long-term complications. Prevention is key. So to prevent a brain stroke or a cardiovascular disease, the patient has to maintain not only tight glycemic control, but blood pressure control. So they'll be on some kind of medication regime and they should stick to it and let their provider know if their blood pressure is not being maintained by the current treatment. Also, you will have to, as a nurse, teach patients how to take their blood pressure and record it daily. Patients should engage in smoking cessation because that helps also lower blood glucose levels. Um, you need to encourage them to continue taking their aspirin and lowering medications. Recall that patients with diabetes can have diabetic neuropathy. They can have silent MI, so they're going to need an EKG periodically to make sure that they haven't had a silent MI. Um, Cholesterol and hemoglobin A1Cs should be tested every 3 months. And how I remember that hemoglobin A1C is a test of compliance is the letter C in there. So in other words, it lets me know if my patient has been compliant with their diet for the last 3 months, right? Because they could cheat and just be compliant the last couple of days before they go to the physician's office, get their glucose drawn, and it could be great. But the hemoglobin A1C test for compliance, and it lets you know what kind of control they've had from their blood pressure over the last 3 to 4 months. Patients can develop diabetic nephropathy, so kidney problems, so they need an annual BUN and creatinine. Their urine also needs to be tested annually for microalbumin. Typically, the kidneys don't spill protein into the urine. However, if the kidneys do start spilling protein into the urine, you know there's some kind of damage with the vasculature in the kidney. And diabetes and hypertension are the two most common causes of chronic kidney disease. Okay, now patients to prevent diabetic retinopathy, tight glycemic control, definitely, and also tight blood pressure control, but they need an annual eye exam. To prevent periodontal disease, they need to have regular dental visits, to have teeth cleaning, and then with peripheral vascular disease and neuropathy, they need to check bath water because they don't have feelings, or they may have the feelings they may have in their lower extremities include like numbness and tingling. Okay, so those are some of the things that they can do to take very good care of themselves. Also, with the diet, no alcohol, no soda, those are good things. They probably shouldn't take acetaminophen or NSAIDs unless prescribed by a physician. Everybody needs to drink 2 to 3 liters per day to flush out the kidneys. And remember that the cornerstone of treatment is diet. And when it comes to diabetes type 2, diet and exercise, and maintaining tight glycemic control is key. Diabetic foot care is extremely important, and you as a nurse will have to teach clients with diabetes how to take very good care of their feet. They need to see a podiatrist at least once a year. They never want to soak their feet in hot water. Okay, inspect feet daily. That's very important. They need to check between their toes. Clean with soap and warm water. And then you want to make sure the skin is patted dry very well. Clean socks every day. I mean, you really need to tell patients about that. Cut the toenails straight across if it's allowed by the podiatrist. Keep the feet dry. They can't go barefoot because they can't feel if they stepped on something that they could have, a little abrasion or cut on their feet, and that just opens the skin up to bacteria. Okay, apply lotion to feet, but skip between the toes. No lotion or powder between the toes, and then they need to wear proper fitting shoes. So make sure they have heels, like they shouldn't wear slingbacks, etc. And then they need to bring an extra pair of shoes on vacation, because if one set of shoes gets wet, they have another set to wear. And trim toenails straight across. I think I said that. Make sure that the room that they're sleeping in is set up and that they're not going to fall or trip over anything. Um, that's another thing they need to worry about with peripheral neuropathy if they can't feel their feet very well. There are exercise guidelines that diabetic patients need to follow, and you need to teach them these key points. So before exercising, they need to take their blood sugar. It needs to be between 80 and 250, because you don't want the blood sugar to go really low during exercise. They need to wear proper footwear for all those reasons I talked about in the previous slide with foot care. No exercise if ketones are present in the urine. So you're going to teach your patients, if their blood sugar goes over 300, they also need to be checking for ketones in the urine more frequently. And I mentioned before, ketones are the breakdown of fatty acids in the body. So in other words, for some reason, the cells are not getting insulin, and so now the body is breaking down fat. You want to teach all patients to carry medical alert ID, but also they need to wear it when they're exercising. Check blood sugar more frequently in the 24 hours after an intense workout. Very important guidelines for exercise. As a nurse, you'll have to teach the diabetic client about illness guidelines. Like, for example, they need to notify the provider if their temp is greater than 101.5. They also need to notify the provider if they have ketones in their urine. If their blood sugar is greater than 200 and it doesn't resolve with treatment, they need to call their provider. And of course, if they start getting rapid breathing, because that could indicate they have Kussmaul's respirations. And if they can't hold down liquids, because typically if patients are ill and their blood sugar goes low, you're going to have them drink, those fast forms of glucose, such as soda. Now, you're going to encourage them. They need to take their blood sugar, if they're ill, every 2 to 4 hours. They need to continue taking their insulin and oral medications. When your body is under stress, it's going to be more prone to get a high glucose level. It's due to the sympathetic nervous system being activated, okay? So that's going to increase the glucose level in their bloods. You want to encourage patients to test their urine for ketones if their blood sugar goes greater than 300, and call the provider if they do have ketones. If you recall earlier, ketones are an indication that the body is breaking down fat because they are unable to use the glucose to nourish the cells, okay? And call the provider for ketones. Right. Now we're going to talk about insulin. I know you had this in pharmacology, but rapid acting insulin works in about 15 minutes, okay? You can remember the types by the mnemonic lag. Short acting, remember that's your regular insulin, and that takes about 30 minutes to 60 minutes to become activated. And then discard if it's cloudy, because regular insulin should be clear. And remember, when you are injecting air, it's cloudy to clear. And when you're drawing up, it's clear to cloudy. The intermediate form of insulin, or intermediate acting, is NPH insulin, and it is the only insulin that could be administered with regular insulin, and it is cloudy, so don't be tempted to shake it, because you're not supposed to shake the vial before you draw up the insulin. Then the long-acting insulins, these are given once or twice daily, and the reason they're given is that they prevent peaks and troughs in a glucose level. So what that means, it's very important that you give it at the same time every day, so there's a steady state blood sugar level. And then with the ultra long acting, these are 3 times more potent than than any other type of insulin, okay? Because we usually give U100 insulin. This is U300. So it does come in a pre-filled syringe if you need to give ultra long insulin, and that's to prevent medication errors. And so it has a duration longer than 24 hours. So metformin is an oral medication, oral hypoglycemic for type 2 diabetics. It works by decreasing the production of glucose by the liver. Therefore, you're going to look for signs of liver toxicity, such as jaundice or yellowing of the skin, okay? It increases their tissue sensitivity to glucose so that insulin can work inside the cell. Monitor for GI issues like vomiting, anorexia, and nausea, and flatulence. Diarrhea is another GI side effect of metformin. You need to hold it for 24 to 48 hours, 48 hours being preferable, before and 48 hours after tests with contrast dye to prevent kidney damage or kidney failure and lactic acidosis. Okay, so that's very important. Those are important interventions. Okay, there are two conditions that are life-threatening that can happen in diabetics, and depending if you have diabetes 1 or diabetes 2. So let's start with diabetic ketoacidosis, which occurs in type 1 diabetics. The onset is going to be very fast. So usually the patient may have like an infection of some sort, and this comes on really fast. Blood glucose is going to be 300 to 800 milligrams per deciliter. Usually it's less than what we would see in HHS, okay? Osmolarity is going to be high. And then with hyperglycemic hyperosmolar state, it's going to be very high, higher than usually DKA. The findings of diabetic ketoacidosis include the acetone breath, okay, and Kussmaul's breathing, ketones. So again, the body is breaking down fatty acids to nourish itself. They could have shock. So that means they could have tachycardia, tachypnea, and then finally their blood pressure will be low. They'll have extreme hunger, polyphagia, and thirst, polydipsia. They are going to be extremely dehydrated, so look for those signs of dry mucous membrane, skin tinting if they're young. Remember, older adults, that's not a valid sign to use. Altered mental status, weight loss, dry flushed skin, and headache. That's what you're going to see in somebody with DKI. It's treated with IV insulin and IV fluids, and the ABGs are going to show metabolic acidosis. Now with HHS, this happens in type 2 diabetics. The onset is going to be gradual. The blood sugar is going to be higher. It's going to start like greater than 600. Osmolarity is going to be extremely high. The normal osmolarity is 285 to 295. So in DKA, it's high, but in HHS, it's extremely high, like greater than 320. They're going to, with HHS, they will have an altered mental status. So you need to watch out for confusion, disorientation. They're going to have major dehydration. So all those signs and symptoms you learned last semester about dehydration, like the fast, thready pulse, okay? Dry mucous membranes, flat veins. So remember all those signs and symptoms. And this is going to be treated with IV fluids, IV insulin, and typically the pH is greater than 7.3. In other words, typically they don't get acidotic. All right, here's what treatment with DKA comprises of. You can remember the mnemonic UCking DKA. So fluids is going to be your first line. You're going to be giving them a lot of fluids because they're dehydrated. You also give a lot of fluids to people with HHS. Urea, you want to monitor the BUN. You want to monitor the creatinine as well. For potassium, or usually in the beginning of DKA, they're going to have a high potassium because of the metabolic acidosis. So you need to check and replace it. As you give insulin and sugar, the potassium will move inside the cell. So you need to check it and make sure they have a urine output before you give any potassium. They may need an NG tube. Glucose, you're going to give um, once levels drop to 250. Once the blood pressure gets to 250, you're going to switch your fluids from normal saline or 0.045, I'll go into more detail in a minute, saline to give fluid with D5 in it. Diet, once they can start eating, hopefully you can encourage them to eat. Keep track of the bicarb if we needed to correct acidosis. Anion gap, you're not going to need to really know about an anion gap for your NCLEX, okay? But the other interventions are very important. In general, patients with either DKA or HHS, this is a medical emergency, right? So vital signs Q 15 minutes until they're stable, then Q 4 hours. Monitor for dehydration, so go back and look at your MedSurg 1 notes about dehydration or look up dehydration in your MedSurg book, the signs and symptoms. Older adults, you want to monitor for pulmonary edema, especially as you start adding more fluid, okay? So the crackles, S3 heart sound, JVD, all those signs and symptoms of pulmonary edema. Patients are going to need rapid infusion of normal saline, then they're going to switch to 0.45 normal saline, and they're going to need IV regular insulin to get the blood sugar down. You want to monitor the potassium. Early on, the potassium is probably going to be high in both conditions for different reasons. Check the urine output before administering potassium. Look for signs and symptoms of high potassium, and then once that is corrected, low potassium.